Could you introduce yourself, Jen?
I'm Jen Meinhardt. I'm one of the A-NUMs for anaesthetics recovery.
How do you feel about ventilation in recovery?
Ventilation in recovery is a very varied thing in the sense that not all of our staff are able to actually look after ventilated patients. There is a select few, and I think they're sort of diminishing as time goes on. So it's not always appropriate to have a ventilated patient in recovery.
Do you think the novice program affects that at all?
Yes, definitely, because we are finding at the moment that trying to get anaesthetic recovery nurses is becoming harder, and therefore we are having to introduce more novices to the program, and they come in from backgrounds which is not an ICU or critical care background.
And with the equipment side of things, do you find that we actually get enough education and the most recent equipment available?
No, we don't. At the moment we've got some of the older ventilators. We do share some of ICU's newer ventilators, but then again, with the new ventilators, not everyone that has worked in ICU is au fait with them, and so that poses a problem of being able to look after a patient connected to them.
And with the staffing level in recovery itself with an intubated patient, I know it's one-on-one, do you find it hard to actually find support for that nurse that's looking after that intubated patient?
Yeah, definitely. Some days we may only have one critical care trained nurse that can actually look after the patient, and the other staff around may not be happy to look after or help out because they're not really they don't really understand the mechanisms of ventilation, and they find it easier to sort of stay away rather than assist.
And after hours, do you find it's hard to get support for the nurse with staffing from, say, ICU or other anaesthetics?
Yes. Yeah, definitely. We do have a nurse liaison service. It's affiliated with ICU, and we should really be making sure that they're aware that there is a patient in recovery, but they're only working till 12 o'clock. So after midnight, we're relying on the services of the consultant in charge, which is the anaesthetist, and other anaesthetists around, and also ICU. And some days that may be feasible, but other days, if we have traumas in and ICU is full to capacity, that poses a problem.
With things like BiPAP, do you have trouble accessing that service if it's needed urgently?
We do have one of the wards here at the Alfred that is a respiratory ward, and they do have respiratory nurses that are affiliated with that. The person in charge should know where things are and be able to access to give out the BiPAP. We would normally go to ICU as well, but again, some people don't understand how to use it, and again, you need an anaesthetist to provide support if you have a non-critical care trained nurse.
And it's a very busy unit, I'm guessing, so you don't always get that support, is that right?
Absolutely, yes.
Thank you very much, Jen.
Thank you.